Good afternoon, everyone. Myself Pinky Patel. I am presenting clinical spectrum of optic neuropathy due to indirect trauma in Tertiary Eye Care Center, Jharkhand. Introduction. Indirect traumatic optic neuropathy is an indirect injury to the optic nerve following an episode of trauma that lead to reduced vision and apparent pupillary defect. Indirect trauma is caused by the transmission of force to the optic nerve from a distant site without disruption of normal tissue structure. Indirect traumatic optic neuropathy has been hypothesized to result from shearing injury to the intracanalicular portion of the optic nerve, which can cause axonal injury or disturb the blood supply of the optic nerve. It has also been suggested that the optic nerve may swell in the optic canal after trauma, resulting in increased luminal pressure and secondary ischemic injury. Indirect traumatic optic neuropathy is seen in all cases of closed head trauma. In India, it is estimated that over 5 lakh people suffer from some of head trauma every year. Aim of the study to find out cause, visual outcome, clinical feature of indirect traumatic optic neuropathy. Material and method. Study design retrospective hospital-based observational study. Duration of the study 1 year. Sample size 20 cases associated with indirect traumatic optic neuropathy who present Department of Ophthalmology. Informed consent was obtained from each patient. Inclusion criteria: all patients who are diagnosed with indirect traumatic optic neuropathy were included. Exclusion criteria: patient diagnosed with direct trauma optic neuropathy or penetrating injury. At the time of presentation, demographic detail: age, gender, number of days of presentation after injury. Examination include best corrected visual acuity, near vision, color vision chart, extraocular movement, pupillary reaction. Anterior segment examination by slit lamp biomicroscopy. IOP was measured by Goldman applanation tonometer. Dilated fundus examination by direct or indirect ophthalmoscopy. Visual prognosis can also be estimated by using BEP, optical coherent tomography. Humphrey visual field done by visual field detect MRI, orbit and brain was done. Result: 20 patients out of which 14 male, 6 female. The median age group 12 year to 51 year. Occupation wise distribution. Most common occupation affected patients were student, followed by manual labor. The mean time of presentation after injury 16 plus minus 10 days. Cause of indirect traumatic optic neuropathy. Road traffic accident is a leading cause of traumatic optic neuropathy, followed by fall and sports injury and fight among friends. Visual acuity at presentation. PL negative 4 patient, PL positive 6 patient, 6/60 10 patient. Visual acuity after follow-up in indirect traumatic optic neuropathy. PL negative 4 patient, HM positive 3 patient, FC 1 meter to 5 meter 7 patient, 6/60 5 patient, 636 1 patient. BEP finding in indirect traumatic optic neuropathy. BEP pattern at presentation was executed almost all subjects except 4 patients. Visual field defect in seen indirect traumatic optic neuropathy. Visual field were not recordable in 15 patients and the remaining subjects saw field defects such as hemianopia, generalized reduction in sensitivity, central scotoma. Associated ocular complication of traumatic optic neuropathy. The commonly associated complication with indirect trauma was orbital fracture, out of which 2 were including brain infarct. Other common complication: angle recession and lid tear. Out of 20 patients, only 6 patients received IV methylprednisolone along with oral steroid therapy, and 14 patients were treated with topical antibiotic, topical steroid and nutritional supplement. IV methylprednisolone along with oral steroid in 1 week of trauma has shown improvement in visual acuity of greater than 3 lines in 2 out of 3 patients. Only 1 of the 4 patients who presented 1 week after injury and received IV methylprednisolone therapy has improved visual acuity better than 3 lines. Discussion. Indirect traumatic optic neuropathy is an uncommon but often devastating cause of permanent vision loss. Indirect traumatic optic neuropathy due to the non-penetrating effect of trauma. The mechanism include bony fragment trauma, optic nerve sheath hematoma, concussion injury, which occurs when trauma is imparted to the skull and transmitted into the optic nerve. Previous report from India were mainly study either the visual outcome or associated complication and treatment strategy. This is the first study which reported additional clinical features such as visual field defect, pattern BEP response along with etiology, visual outcome, associated complication in indirect traumatic optic neuropathy. Conclusion. Indirect traumatic optic neuropathy is sight-threatening condition, may common comorbidities of blunt superficial head trauma. Most of the indirect traumatic optic neuropathy are usually young male, and the main cause of traumatic optic neuropathy in RTA in Indian population presenting visual acuity of greater than 660 and recordable pattern BEP may be prognostic factor for improved visual outcome in traumatic optic neuropathy. Most of them traumatic optic neuropathy in the current study were treated with conservative treatment. However, results from current study provide insight the IV methylprednisolone along with oral steroid within a week of trauma would help to the patient recover faster with visual outcome. In the study, 3 major OCT findings were demonstrated in the out of the temporal retinal nerve fiber thinning was.
You have crossed the time.
These are my references. Thank you.
Thank you.
So, what you in your paper you mention indirect traumatic optic neuropathy. What is the aim of this? Why you label it as indirect, not only traumatic optic neuropathy? On what basis, on what background you are label it as indirect traumatic optic neuropathy?
So, head trauma.
Pardon?
Why you have labeled this as indirect traumatic optic neuropathy? What he means to say? What is the difference with direct optic neuropathy and indirect optic neuropathy?
What is the difference?
Okay, just as a competitive session, I am asking another question. What is APD and what is RAPD?
Sorry.
APD and RAPD.
Relative apparent pupillary defect.
Yes, and what is APD?
Apparent.
Remove the R, it becomes apparent pupillary
It's
defect.
very important in case of a rototrophic trauma, as you are mentioning indirect. So that's very important in case of a bilateral, what you will label. Most of the time, you people, the generally resident, they are labeling as a RAPD is not a correct form. This is basically APD. And as a competitive, again, I have to ask another question. So, what is the common pathology, common etiology of it is for a traumatic optic neuropathy? Is as you already mentioned, direct and indirect. It is a direct trauma or it is some other else? What is the common cause, common etiology of traumatic optic neuropathy in total?
Retinal nerve fiber thinning.
Pardon?
Retinal nerve fiber. Commonest.
Nerve ischemia.
Nerve ischemia.
Why? Suppose you are telling nerve ischemia, why?
Which disease? Central retinal artery, spiral vessels. Which of the vessels?
And central retinal.
Okay, okay.
Next presenter, please.
Very good morning, everyone. Today my paper is on the role of OCT in differentiating between glaucomatous and non-glaucomatous optic neuropathy. There's no conflict of interest or financial disclosure. So glaucomatous optic neuropathy is one of the most prevalent causes of optic nerve atrophy and cupping due to ganglion cell loss or death and retinal nerve fiber layer or RNFL thinning. Non-glaucomatous optic neuropathy presents with optic disc pallor and or cupping, which can sometimes mimic glaucomatous disc changes. So the changes in the optical coherence tomography or OCT measurements in the RNFL layer and the optic nerve head can serve as an invaluable tool in diagnosis and monitoring of the optic neuropathy. The aim here is to study the role of spectral domain or SDOCT in differentiating between GON and NGON by comparing the mean peripapillary RNFL thickness in the different sectors as well as globally. So a cross-sectional hospital-based study including 55 eyes of 55 patients from November 2023 to April 2024 were taken, out of which 30 were GON patients and 25 were NGON patients. The Heidelberg Spectralis SDOCT and SPSS statistic software were used for analyzing the results. The exclusion criteria are patients less than 18 years of age, mixed or unclear diagnosis, high refractive error or axial length, any media opacity leading to poor quality of OCT, unreliable HPF testing, secondary glaucoma or any other retinal pathologies like diabetic retinopathy or retinal laser treatment. Now after informed consent and history taking, the best corrected visual acuity of the patients were assessed, followed by color vision, RAPD, intraocular pressure with GAT, slit lamp examination including 90D, indirect ophthalmoscope, 24-2 Humphrey visual field analysis, neuroimaging wherever necessary, and SDOCT. So the results showed that the mean age distribution in the GON category was higher as compared to the NGON category, that is the 5th to 6th decade, whereas in NGON it was 3rd to 4th decade. And in our study, there were more number of female patients in the GON category and more number of male patients in the NGON category. Now out of all the NGON patients that we took, maximum number belonged to the previous optic neuritis category, followed by compressive optic neuritis, which is your malignancies, and then NAION, traumatic optic neuropathy, and toxic optic neuropathy. As we can see, RAPD and color vision defect were more prevalent in the NGON category of patients, whereas visual field defect was more common with the GON. Now, upon conducting the SDOCT, we can see that significant peripapillary RNFL thinning was seen in the temporal, that is the inferior, that is temporo-inferior and naso-inferior sectors, followed by the superior quadrant in case of the GON cases, whereas it was more number of RNFL thinning was seen in the temporal, followed by the nasal sectors in the NGON category. Here we can see again the first picture, the glaucomatic optic atrophy. We can see again inferior and superior quadrant thinning, whereas these are the different types of some of the NGON patients where we can see different areas of RNFL thinning depending on the cause. Now this is the fundoscopy images separating the glaucomatous cupping from the different changes that happen in NGON. And the ONH scan again revealed that glaucomatous optic neuropathy showed cupping, whereas NGON showed pallor, cupping or disc edema depending upon the etiopathogenesis. Coming to the discussion, Liu et al. Have described that the best parameters to detect glaucoma using OCT are below normal inferior, superior or global quadrant mean RNFL thickness, and it was also reinforced in our study. Quigley et al. Showed that the pattern of RNFL thinning in glaucoma tends to be greater in the superior and inferior quadrants, while that of NGON varied depending upon the etiology, which was the same finding in our study. When Novel et al. Showed that optic neuritis patients correlated the degree of visual acuity with the axonal loss in OCT RNFL scan, which can be seen before the presentation of visual field, significant visual field defect, which was again seen in our study. So the limitations of this study are that longitudinal study can better help to establish the results of this study, and inclusion of other measurements like macular volume or BMO minimum rim width can be also more conclusive, but RNFL remains the superior criterion. So my take-home message is that OCT can be a novel, non-invasive diagnostic tool along with the clinical findings to differentiate between the NGON and GON category of RNFL thinning, and it can also help to plan our treatment according to this. So these are my references. Thank you everyone for your patient hearing.
A good presentation. In
Thank
your non-glaucomatous cases,
Yes.
particularly with the pituitary adenoma, so did you how many of them had like an edema at presentation? How many had atrophy? Even the NAION, did you do it in acute phase or did you do it once they had the pallor?
Because it was a cross-sectional study, so I took the scans right on the day that the patients presented. So some of them had presented at the edematous stage and some of them presented when there was already atrophy. So that is why I have
Yeah, I saw the thing.
That is why I taken different fundus pictures and of the different presentations.
Because like if you, in your study, if you had to categorize the RNFL thickness, it
Yes.
depends whether if it is in a
Edema or
edema
atrophy.
stage
Yes,
or
ma'am.
in a atrophy stage.
Yes, ma'am.
It would be better if you want to do a study to take all of them in atrophy stage.
Yes.
Then it would be valid to
More uniform.
correlate between glaucomatous atrophy and non-glaucomatous atrophy, because the moment edema comes into play, it will be thicker RNFL.
Yes.
And in your toxic nutritional amblyopia,
Yes.
which sector was more affected? In your
Um,
toxic, in a toxic nutritional amblyopia, what are the RNFL, like which fibers are more affected?
So, ma'am, as
Superior,
we,
temporal, medial, lateral. What are the
Yes.
fibers which are specifically getting affected?
it's mostly the temporal followed by the nasal fibers which are being affected.
Specific, what are the like arrangement of your nerve fibers? Okay.
It's the superotemporal and inferotemporal fibers which are getting
You
affected.
get a central scotoma,
output.
right?
Yes,
So
ma'am.
it's usually your papillomacular bundle. So you should usually demonstrate that.
Okay.
Because we are using it for a higher analysis, not just the clinical thing, but you
Yes.
could have done that, I guess.
So macular volume measurement would have been a better addition to this, but our OCD did not have those provisions.
Is there any role of repeat OCT in such cases?
Yes, sir. Repeat OCT generally, if had it been a longitudinal scan where we could monitor the patient, the prognosis, and the repeat serial OCTs we could have taken, then that helps to establish the thinning, the degree of thinning more. And that is why nowadays we also have built-in serial analyzers in the OCT itself, which
Yes.
will help to maintain the record, and that also establishes this
That's
result.
why I'm
further.
asking, in your case it was done or not?
No, sir, this was a cross-sectional study.
Yes.
So I
that's
mentioned it in
very
my
important.
limitation.
This is the
Yes.
last step.
Yes,
Most of the time, clinically you can diagnose it.
yes,
And madam also mentioned, so depending on the, it may be trauma or it may be due to the other all factor, we can levelize it. But serial examination is the step in such
Yes.
cases. Then only by one study is not, a one-time
Yes.
study is not possible.
yes. So that is the
Why?
limitation of my
Why?
study, as I mentioned.
Why?
Yes.
What clues you can in a next follow-up?
Sorry, sir.
Next follow-up, what may be the clue in a non-glucomatous, over the glucomatous? What will be the difference you can think for in future? Suppose today you done one set. So one best is that is not possible to rule out all. So in second
Yes.
after you 2 month, 3 month, if you go ahead, then what will be your outcome? Can you tell me something?
So,
In glucomatous, what will be and in non-glucomatous, what may be the
so
finding?
in glaucomatous, there is progressive RNFL thinning
Yes,
and
yes,
something which is called as secondary degeneration. So that once even the IOP has been lowered also,
Is
but the
impossible.
adjacent
In
cell-
glucomatous, improvement is impossible.
impossible. It
But
is
in
irreversible.
non-glucomatous, there may be a possibility. It may
improvement.
not.
Yes.
That's all.
Thank you.
Thank you.
Good afternoon. I am presenting the effect of NDI of posterior capsular opacity on a AC depth and the refraction in the pseudophakic eye. Introduction part, the posterior capsular opacification of the secondary cataract is the most common long-term complication of modern extracapsular cataract surgery. The complication is as the decreased visual acuity, impaired contrast sensitivity, glare disabilities, and the monocular diplopia. The standard treatment of the PCO is NDI laser posterior capsulotomy, which has success rate of more than 90%. The laser capsulotomy used as a quick pulse NDI laser to apply a series of focus ablation in the posterior capsule and create a small circular opening in the visual axis. The primary goal of the study was to examine the influence of the NDI laser capsulotomy on refraction and AC depth. The complication of the ND-YAG laser posterior capsulotomy as the retinal detachment, cystoid macular edema raised in IOP, shift in the position of the implant. The protocol of this study was therefore to perform the ND-YAG laser capsulotomy after at least 3 months from the cataract surgery or at least 1 month after the intraocular inflammation had resolved. The inclusion criteria are the diagnosed case of glaucoma and steroid responder, corneal opacity, retinal diseases, uveitis, optic neuropathy, and surgery prior to ND-YAG laser capsulotomy. The methodology, this is the study. Study was a prospective and descriptive study. The declaration of Hansky and informed consent was taken from the patient before the intervention. Total 53 pseudophakic eye of the 43 patient with the PCO with the best characterized visual acuity is less than 6.9 were included in the studies. Only uncomplicated in small incision cataract surgery or and phacoemulsification with the posterior chamber intraocular lens implanted surgery was included in the study. All the patients underwent ND-YAG laser capsulotomy from January 15, 24 to August 14, 24 in RIO-REMS. Patient was divided into 2 groups according to total energy used during the procedure. In group 1, the total energy exposure is less than 50 microjoule, and in group 2 more than 50 microjoule. All the patient underwent a complete ocular examination on all visit, including the VCVA, refraction, slit lamp biomicroscopy, IOP measurement, and OCT was used for the macular thickness. The IOL Master 500 were used to measure the AC depth. The combination of the topicamide 0.8% and the phenylephrine 5% was administered for pupil dilatation and prior to procedure. After the capsulotomy, a combination of the antibiotic and steroid were prescribed for 4 times daily for 7 days and anti-glaucoma drug 2 times for 7 days. They were examined pre-operatively and then 1 hour post-operatively and after 2 weeks after the capsulotomy. The result is 28 male and 15 female patients were enrolled in this study. 23 patients received treatment in unilateral eye and 10 patients in both eyes. The table shows the divided into 2 groups. Group 1 is received total energy less than 50 microjoule and group 2 is received more than 50 microjoule. ND-YAG treated eye are the 32 in group 1 and 21 in group 2. The mean duration of surgery is 2.2 year in first group and second group 4.8 year. The table 2, the total energy exposed in group A is 26 plus minus 12 and group 2 is 81 plus minus 32. The spherical equivalent pre-treatment is minus 0.39 and in second group 0.4, minus 0.4. After the 1 hour of treatment, the spherical equivalent is 0.5 and in group 2, in group 1 0.35 and group 2 is 0.36. In after the 2 week of the post treatment, the spherical equivalent is going to minus 0.34 and 0.37 in group 2. The AC depth of pre-treatment is 3.9 in group 1 and group 2 is 3.96. And after the 1 hour treatment, the AC depth goes 3.952 in group 1 and group 2 is 3.98. After the 2 week of post treatment, the AC depth goes 3.97 in first group and 3.99 in second group. The comparison between the between two parameters are after the 1 hour treatment in group 1, changes occur in 0.03 in group 1 and 0.03 in group 2, almost is equal. AC depth.
Just take can go to your last slide.
Okay.
Conclusion, yes.
The conclusion is best character visual acuity improved significantly after the ND-YAG laser posterior capsulotomy in healthy pseudophakic eye with PCO. There is usually no need to repeat refraction. AC depth 2 increases after the ND-YAG laser capsulotomy. This is my references. Thank you.
Just first of all, one simple question. This is a paper of cataract and refractive surgery basically. Why you choose in under the category of neuro?
Sir, it is taken by mistakenly, sir.
Yes. It is by mistake by
yes,
that.
Yes.
Okay. So So ideally you can, I think, deprive because of this our error, system error. Okay. Anyway, it is not exactly in a version, but
You have mentioned 2.9 AC there, but you have shown 3.9 fast. Second, what is a descriptive study? Prospective, retrospective, cross-sectional, longitudinal. What is a descriptive study? These terms you should be careful because you are competing and you are postgraduate student. So these things you should remember. Okay.
Manish Upadhyay, Manish, Dr. Manish. Uttar. That's okay, please share. Shwati, yes, yes. Yeah, yeah, first. Other whole, I think. Okay, please start.
Very good afternoon, everyone. So, my presentation is on neuro-ophthalmic manifestation of head trauma. Head injuries are common cause of visual impairment in head trauma patients. So, early detection of neuro-ophthalmic symptoms is very important for diagnosis, management, and the prognosis of patient. But unfortunately, due to periorbital swelling and hematomas, this is delayed. My aim is to determine neuro-ophthalmic findings in patients with head trauma and to correlate with severity and type of head injury. Um, it is hospital-based cross-sectional study of 25 patients of more than 10 years age group. It is done in a period of 3 months in tertiary eye care hospital in Chhattisgarh from December to March. My inclusion criteria are patients with definite history of head trauma with ophthalmic symptoms who have good level of consciousness and who are more than 10 years age group. Exclusion criteria is below 10 years age group and who are unable to come for follow-up. My method of data collection is after taking proper ethical committee decision and proper consent, I took history of patient regarding head injury, the level of consciousness, ENT bleed, etc., visual acuity with Snellen's chart, color vision with Ishihara chart, pupillary response by torchlight, and anterior and posterior segment examinations. It was followed by X-ray head and orbit with NCCT head and orbit, and results were interpreted. My statistical analysis was done by SPSS version 22 software by two-tailed method and assuming type 1 error and probability p-value less than 0.05. Result were study participants ranged 20 to 50 years and it was male predominant. Results showed maximum head injury were due to RTA followed by self-fall, assault and blunt trauma. My vision at presentation of patients were mostly falling in category of 660 to 160, 1 by 60 and no PL was found in 4 patients. Orbital fracture floor was the maximum fracture I saw, that is 7 patients, followed by medial wall 3 patients and lateral wall for 5 patients. This is the clinical profile of soft tissue injury, which shows that ecchymosis and subconjunctival hemorrhage was most common among all. Result: most frequently encountered neuro-ophthalmic abnormality was optic neuropathy in 13, that is 52% of patients. They showed RAPD, and efferent pathway defect was found in 12, that is 48% of cases, in which oculomotor nerve palsy was most common, followed by trochlear nerve palsy. These are the neuro-ophthalmic manifestations found in my patient, which we can see optic nerve injury was the most common among 76% of patients, followed by oculomotor nerve palsy, abducens nerve palsy, diplopia and ptosis. Result is mode of injury didn't correlate with outcome. Presence of any neuroimaging abnormality was significantly associated with neuro-ophthalmic deficit, and presence of orbital wall fracture was associated with trochlear nerve palsy, while contusion was associated with traumatic optic neuropathy. The severity of head injury was compared with the patients having RAPD or not, and we saw that maximum patients with severe head injury had RAPD. Discussion. Head injuries often affect visual system, making detailed eye examination crucial for assessing injury and prognosis. And epidemiology of specific neuro-ophthalmic findings might be helpful for clinician to have a higher index of suspicion. Road traffic accident was the most common cause of head trauma, and young males were frequently affected. Ophthalmic manifestation in my study included soft tissue injury in 46.6% of cases, orbital fracture in 13%, and neuro-ophthalmic abnormality in 10% patients. The most common orbital fracture is blowout fracture, where the direction of impact is from front, and our study has similar findings. In our study, oculomotor nerve palsy was the most common, followed by trochlear nerve palsy, in line with study done by Van Stavern et al. The abducens nerve, though prone to injury and commonly involved in palsy, was the least affected in our study. Among the afferent pathway deficit, optic nerve injury was the most common. Our study showed indirect optic nerve trauma more than direct one. Neuroimaging abnormality, that is skull fracture. Yes, ma'am. Ma'am, my study was done among 25 head injury patients. Yes, ma'am. Yes, ma'am. My study was done among 25 patients with head injury who were more than 10 years age group and having some neuro-ophthalmic or ophthalmic manifestation. So I concluded that in my patients, maximum patients were having optic nerve injury, that is afferent pathway defect was found in most of patients, followed by efferent pathway defect having most common oculomotor nerve palsy, followed by trochlear nerve palsy.
You told in the beginning the GCS score.
Yes, ma'am.
So you have excluded. So why you have excluded?
Ma'am, I have excluded because for neuro-ophthalmic manifestation, I have to see color vision of patient, and I need some cooperation from patient for visual acuity. That's why I included only conscious patients whose GCS was good.
But I think those are the patients who would actually have a lot of neuro-ophthalmic manifestations, because that will skew your findings. It would be better like you follow them up after 4th or 5th day when the GCS becomes better, because then your manifestations, everything will change. Because you yourself have concluded that the ones who had contusion had more problems, and any on CT, if they had any imaging findings, they are more likely to have the neuro-ophthalmic findings.
Yes, ma'am. I found the orbital wall floor fracture.
I just meant
yes,
that you should have also included the ones with a very poor GCS score, because they are the ones who will have more
findings. Yes, ma'am. Sure. Thank you.
Ma'am directly mentioned, so you can label it as a GCS score, that amount will go for 9, 8 or whatever. You can just label it. It is otherwise it is a tag. So many questions may come that way. And you are mentioning one of your slide, X-ray. Is there any role of X-ray and today's era?
Sir, like patients with poor socioeconomic class come to us. First of all,
are you from a private hospital or
government
college?
Government setup.
Is it available or not? CT scan.
Sir, CT scan is available, but X-ray is very
no, that's it. So
common.
we generally always we tell as a poor socioeconomic is a insult to this patient, because in government everything is free. Even in the private there is no such role. Even we need a MRI, we can go for a very quick scan of CT. We can save so many money, so many years. Quick scan, there is a term is a quick scan. No need for any CT scan, as all of you are maximum resident. And if you are thinking for that maximum time we may go for a MRI
Yes, sir.
or MRA.
Yes, sir.
There is no such role of CT scan. If required to rule out only one condition, then only you can go for. Don't you will be in trouble then in competitive
sir.
session. If monsoon you may want that thing. This is the art. Okay.
Thank you, sir. Thank you, ma'am.
Good morning everyone. I am presenting a paper on firecracker related Berlin edema, Diwali's hidden hazard health. Celebration of Diwali comes with bursting of firecrackers, and it also has a hidden health hazard with a potential of serious consequences, in which one of these is Berlin's edema, which is a rare but significant ocular injury resulting from the expulsive force of the firecrackers. In this case series we have patients who presented to the emergency department for 2 consecutive days at the day of the Diwali and 1 day after the Diwali, and the patients underwent comprehensive ophthalmic examination. Visual acuity was taken by finger counting or Snell's chart. Additionally, all patients underwent complete slit lamp examination and fundus examination at the time of presentation and at follow-up visits. Patients diagnosed with Berlin's edema were closely monitored and their visual outcomes were evaluated. The type and mode of firecrackers were also taken into consideration, and the specific types of injury they caused was also taken into the consideration. So we'll start with the cases. The first case is a 30-year-old male who presented to the emergency. The patient had a history of trauma to the right eye from the particle of a bullet bomb. The patient was 10 feet away from the bomb, standing, and at the time of presentation, the uncorrected visual acuity in right eye was hand movement close to face, and left eye was 6/6. In slit lamp examination, AC reaction was present, RAPD was present in right eye, and subconj hemorrhage was present temporarily with gunpowder embedded in it. On the next day, in fundus picture, we can clearly see there is a media is hazy due to vitreous hemorrhage. There was a well-marked Berlin edema, and FR was dull. In the second day, the vision did not improve for the patient. It was hand movement close to face, and left eye was 6/6. In OCT, we can see there is central macular thickness is 212 micrometer, and it also shows perifoveal hyperreflective areas, including the upper layer of retinas. In treatment, the patient was started on oral corticosteroids according to the body weight. Eye drop, Predfort, Nepafinac, Homide, and moxifloxacin and CMC was started. The patient was regularly followed up for 3 months, and the patient's vision improved from hand movement to 6/6 with decrease in AC reaction and vitreous hemorrhage, and no complaint by the patients. In second case, a 9-year-old male patient presented to the emergency with a history of trauma to the right eye with Lakshmi bomb. The patient was burning cracker in his hand, throwing it away when a particle of the bomb hit him. His uncorrected visual acuity in right eye was hand movement close to face, and left eye was 6/6. Slit lamp examination showed AC reaction +3. Hyphema was present, and subconj hemorrhage was also present with gunpowder embedded in it. In day 2, the visual acuity was 3/60. In the fundus photograph, we can see the media is hazy and well-marked Berlin edema is present around the disc. The FR was dull in this patient. In OCT also, we can see perifoveal and around the disc hyperreflective areas, including the upper rail of retina suggestive of Berlin's edema. The patient was also given the same treatment. Oral steroids were started, and same treatment, eye drop, Predfort, Nepafinac, Homide, Moxi, and CMC was started. The patient improved vision from 3/60 to 6/6 with decrease in AC reaction and no complaint by the patient. In case 3, the patient presented 22-year-old male presented to the emergency with a history of trauma to the left eye with dynamite bomb. The patient was standing away from when the particle of the bomb hit his eye. His left eye vision was 3/60 at the time of presentation. AC reaction was present. Subconj hemorrhage was present with gunpowder embedded in it, and laceration was present over the left upper eyelid. The right eye fundus was normal fundus. In left eye, we can see there is a pre-retinal bleed which is shown by the star and green arrow, and Berlin's edema was present which is shown by the red arrow. In in OCT, we can see there is a dome-shaped elevation showing choroidal thickness, suggesting of neurosensory detachment in the patient, which is shown by the yellow arrow, and subfoveal deposit of hyperreflective can be present, seen below the neurosensory retina in OCT. The patient was also started on the same treatment, and patient vision improved from 360 to 6/9 with decrease in AC reaction, resolved pre-retinal bleed, and no visual complaint by the patients. In conclusion, we can see the case series demonstrate that restricting the personal use of firecrackers is a proven method to reduce the number of firecrackers, to reduce the morbidity. But in case of Diwalis, the firecrackers are usually used. So if we are using the firecrackers, the use of proper personal protective devices and community awareness has to be done. The distance and the type of characters also determine the severity of the firecrackers' ocular morbidity. OCT is a useful adjunct for monitoring the progress of Berlin's edema. Thank you.
Yeah, you correctly mentioned OCT is useful, but what are the other hallmark features for Berlin's edema? Clinically, what are the?
So like the first patient presented with RAPD, so it means and he was also having vitreous hemorrhage.
Vitreous hemorrhage, RAPD, maybe due to the other
causes
as
also,
your paper was clearly mentioned is a Berlin's edema. So, but none of your OCT reflecting it. You claim it is in a second day. Second day generally that type of OCT, and it may be PED also in
yes.
one. In OCT, it may be
also.
PED, pre-existing PED also maybe,
Yes, sir.
and your is macula area that thickness is not as much as. On what basis you are claiming that those are a Berlin's edema?
So firstly, on the basis of fundus examination, we are clearly stating
That's
that
why
it is a
I'm
Berlin's
asking
edema.
first question, what are the hallmark features? Which diopter lens you will prefer to say Berlin's edema?
So fundus examination will show
Yes.
Berlin's edema.
What type of fundus examination?
So indirect ophthalmic edema.
Is it
Dilated indirect ophthalmic.
direct? No, there is no such role of direct nowadays. Is gone. In our time it was there, but in your era there is no such. I think is not available in the market. So I am asking straight question to you: what are the term to examine basically posterior fundus, that posterior pole?
In posterior pole, we can examination depends upon the visibility of the media of the patient.
If the media is visible,
Yes, sir.
if media is visible, then
So in slit lamp examination, we can do 90.
what kind of slit lamp examination?
Slit lamp examination, 90D examination we can do.
Slit lamp examination one
With
is slit
90D
lamp,
fundus
one
process.
is 90D. Then any other? What are the term of if I examining by a 90D? What is the term? We are examining with a 90 diopter lens along with the slit lamp. What is the term?
90D biomicroscopy.
90D biomicroscopy or slit lamp biomicroscopy?
90D slit lamp microscopy.
Again another question, which lens is best for to detect disc or surrounding area, 78 or 90?
So for for seeing the disc area, 90D is better, and for the periphery we use 20D.
No, I am not asking 20.
90D we will use for. I mean 90D stereopsis is better, and 90D, yes, yes, sir.
Learn to do with both.
Okay.
So it's always better for, for the benefit of postgraduates, if you, it's better to buy the lenses during your postgraduate training so that you get accustomed to see all the findings. Don't depend on institute's equipment, because later once you start practicing, you will need them. Okay, so 78D lens, 90D lens.
We are also trying to helping you. That's not asking the question. The reason is that you people are more techno savvy. that machine may mislead lot. It will be very difficult, and you moment you can take a good clip, you can send faster than us. But in whatever I am observed now, last 25 years, is we did that high tech machines. It is our clinical judgments and day to day, day by day is deteriorating. It will be big issues for us in future, because you're in all OCT. If you send to on WhatsApp or somewhere, we make a is a normal. So should think for your own judgment.
So at the time of presentation, fundus examination was the primary, but at the next
I
day
think
we
it was
preferred for.
taken after few hours. If you
Yes,
claim
sir.
as violence edema, it should not be like that type of OCT.
Thank you, sir. Thank you, sir.
I will just call out the people who have not presented. If you guys have come, please identify yourself. Dr. Manish Upadhyay, Dr. Uttara, Dr. Deepthi. Okay. Have you given loaded? I think just can you please check with them? He hasn't got your presentation. Dr. Mariam. Dr. Mariam. Okay. And we also have a keynote address by Dr. Abipsa. Dr. Abipsa, are you here? Okay. So I think Dr. Deepthi can present, and after that, instead of Dr. Ashi, whoever is presenting, you can present. So we are not having the keynote address and all these other people who haven't come. I think, can you just present directly, because they don't have the presentation.
Good afternoon, everyone. I'm going to present myself on ischemic optic neuropathy, giant cell arteritis, also known as temporal arteritis. Giant cell arteritis is the most common primary vasculitis in adults, involving medium and large size vessels in elderly age. It is considered a medical emergency due to its potential to cause permanent vision loss due to GCA, is arthritic anterior ischemic optic neuropathy. I'm going to present myself on GCA. Like, I'm going to present two cases of GCA. First one being a 62-year-old non-diabetic and non-hypertensive male who came with the chief complaints of sudden paleness, decrease in vision left eye since 3 months. Previously, he was diagnosed as optic neuritis left eye, treated with IV methylpred for 3 days and was followed by oral steroids for 2.5 months in tapering doses, which he stopped a week prior to the presentation. The general examination was normal within normal limits. On examination, the visual acuity in left eye was counting finger at 1 feet. There was RAPD in left eye. Motility was normal in both the eyes. Left eye fundus showed pallid disc edema. On local examination, the superficial temporal artery over the left side on palpation was hard, tender, and cord-like non-pulsatile. Previous investigations were normal, except the CRP was 11.5 milligram per deciliter. On repeat investigation, the CRP and ESR were quite raised. So, which led us to the diagnosis of AION, left eye due to occult GCA. Biopsy was done on the next day and was restarted on IV methylpred for 5 days, followed by oral steroids, 1 milligram per kg body weight, and tapering doses. We took the superficial temporal artery biopsy. First, we palpated it, and LA 2% was given. And with the caliper, 3 centimeter of artery was measured and dissected. And it was sent for histopath, where the findings of superficial temporal artery demonstrated presence of chronic inflammatory infiltrates in the adventitial and medial layers, accompanied by arterial wall calcification. Coming to the case number 2, which was about a 58-year-old non-diabetic, non-hypertensive female who came with the chief complaints of sudden painless loss of vision in right eye for last 3 weeks. Patient also gave history of pain in the jaw while eating and generalized body ache more in the neck and shoulder area 2 weeks prior to the visual loss. She visited to a local ophthalmologist, and the medical records show her vision to be PL positive with RAPD right eye. Disc edema with pallor and superficial hemorrhages were reported on the fundus examination, but no proper diagnosis was noted in the records. General physical examination was within normal limits, and superficial temporal artery pulsation were feeble but non-tender, and it was not hard. On ophthalmic examination, the visual acuity in right eye was PL negative. In left eye, it was 612 with pinhole improving to 6/6 part. Ocular motility was full in all the gazes. There was RAPD in right eye, and in right eye fundus, there was pallid disc edema with superficial hemorrhage. Previous investigations were normal. The ESR was 94 millimeters per hour, and CRP was not asked by the doctor. Rest investigations were normal, including the neuroimaging. On repeat investigation, we found the ESR and CRP both were raised. So we made a diagnosis of AIN due to GCA with systemic symptoms. For management, we sent the patient for USG of superficial temporal arteritis, which showed doubtful halo sign, and patient was planned for vessel wall MRI. Oral steroids were given, and they were increased to a dose of 60 milligrams as CRP levels were still on the higher side. Result, in case 1, based on the above mentioned history, clinical examination findings, and blood investigation results, we made a diagnosis of occult GCA without any systemic association. And in second, there was GCA with systemic symptoms. In conclusion, GCA is supposed to be rare in Indian scenario and often underdiagnosed. Early diagnosis and management is required to prevent the irreversible visual loss in these cases in the fellow eye. Discussion, GCA is most common primary vasculitis in adults, most commonly seen in above 50 years. Women are commonly involved than men, approx 2 to 6 times, and its most common feared sequelae of GCA is permanent visual loss, secondary to AION, and it is considered to be an ophthalmic emergency since the AION can progress rapidly and involve the fellow eye within a matter of days. When GCA is suspected, treatment with corticosteroids is indicated on urgent basis. This is the classification given by American College of Rheumatology in 2022 to classify GSA, where a score of more than or equal to 6 is needed to classify giant cell arteritis, where the absolute requirement is more than 50 years old, and other things we can see. Thank you.
What was the ESR in both of these patients? In the second patient, when you repeated, it was 29. The ESR, yeah, ESR. And in the first patient?
I mean, in first patient, it was 80 something around,
okay.
More than 50.
Yeah, generally because the ESR has to be above 50 to get the diagnosis. And what was the treatment for the follow-up period? What have you put the patient on?
Mainly, first we put the patient on IV steroids for 3 days, and then we shifted the patient on oral steroids and tapering doses.
Okay. So after your steroid is withdrawn,
yes,
what will you do to prevent the GCA in the other eye?
Ma'am, steroids are given to prevent
So have you given, ideally the whole thing about doing a temporal artery biopsy is to prove that it is a GCA so that the patient can be put on a very long-term steroid.
Yes, ma'am.
What is the percentage of involvement of second eye in AION? How much percentage is the risk for the second eye involvement?
Ma'am, 60 to 70% around. It involves the, ma'am, within 1 week it involves the other eye usually.
Okay.
What are the other life-threatening conditions in such patients? We can assume there may be other patient may develop other signs and symptoms. What are the other? Some are life-threatening.
So other signs and symptoms.
No. Other structures also may involvement, not only the temporal artery. It may be fatal for the patient. So what you will do in
So
your
further complications can be.
is not a complication, is a sequelae of that.
So it can further lead to the vision loss in the other eye and.
That's one. I mentioned this fellow eye chances is high. Okay. Any other which may be life-threatening? That's step 2 in the.
So if it involves
management.
other
Pardon?
arteries, then so it can lead to stroke and MI and
Yes. always is a mandatory to take your opinion of immunologist and cardiologist. So is the rheumatologist or immunologist, better term is nowadays immunologist or rheumatologist proper, not only just with a 1 year training of the rheumatology, and the proper cardiologist.
So along with that, we have to give immunosuppressants also.
Always, yes. We take the term is critical care. Under the patient should be under critical care team who knows all. Good presentation.
Good afternoon, everyone. The topic of my presentation is clinical profile of NION and its association with systemic diseases with special reference to OSA. Introduction. Anterior ischemic optic neuropathy is most common acute optic neuropathy affecting adults older than 50 years. AION is basically categorized into two categories, arthritic and non-arthritic. The non-arthritic form of AION is often related to systemic risk factors like diabetes, hypertension, hyperlipidemia, obstructive sleep apnea, and smoking. The aim of the study is to study the systemic risk factors associated with AION to assess visual parameters before and after the treatment. Materials and method. Study center was Department of Ophthalmology, SSMC Riva. Study duration was Jan 21 to June 22. Study design was prospective observational case control study. Study population were 32 cases of AION and 32 age and gender matched controls. The inclusion criteria were patients with characteristic features of AION. The exclusion criteria were patients with other causes of the scleroderma and other retinal and optic nerve pathology that could cause defective vision and field changes. Material and methods. Demographic data of cases and control, detailed ophthalmic and medical history were taken, such as diabetes, hypertension, hyperlipidemia, smoking history, and OSA risk was assessed using stop bank questionnaire. And the relevant lab investigations were done. Comprehensive ophthalmic examination, visual acuity in logMAR unit, the contrast sensitivity, and OH parameters on OCT. Materials and method follow-up was done at 1 month and 3 months. Comparison of risk factor was done by odds ratio, statistical analysis by chi-square test. The mean age of the cases and the control and the male and female ratio were almost similar. Systemic risk factors, diabetes was present in 62%, hypertension in 48.87%, obstructive sleep apnea in 59.37%, hyperlipidemia in 31.25%, and smoking in 40.62%. The significant p-values were noted in case of diabetic, hypertensive, and OSA, with the respective odds ratio of 4.2, 11.57, and 7.8. The results, the initial presentation at 1 month follow-up and at 3 month follow-up, we saw the color visual acuity, the color vision, and the contrast sensitivity. We found that the visual acuity and the contrast sensitivity did not change much, but the color vision was significantly improved. The main systemic disease found to be positively associated with AION were hypertension, diabetes, and obstructive sleep apnea. However, no significant association of smoking and hyperlipidemia with AION was seen. Hyre et al. And Das et al. And Saxena R et al. Also reported similar risk factors to be significantly associated with AION. In addition, Saxena R et al. Also observed a significant correlation of smoking. OSA as a significant risk factor for AION was found in our study, which was similar to that of K. Palombi et al. And Jian Li et al. We found no association of disease with hyperlipidemia, but Vincent A. Demro et al. Study found a positive association of hyperlipidemia with NION. The present study concluded that AION has a significant association with diabetes mellitus, hypertension, and OSA. Improvement in visual parameters were not seen to be marginal in visual acuity and more for color vision and contrast sensitivity. As visual improvement is rarely seen in the affected eye and the other eye is also at risk, so identifying the various systemic risk factors and treating them becomes paramount importance to prevent follow eye involvement. Thank you.
Your presentation is okay, but unfortunately we cannot score any mark. One. Second, in future, if you want to present, always take a permission from the chairman scientific committee. Then if, but yeah, okay, fine. This we allowed, but not score the mark. Okay. Okay, then we can conclude. It is very important